All right, thank you. So this is a 79-year-old woman. She has been diagnosed with atrial fibrillation 4 years ago. Her CHADS VAS score is 4 and her HAS-BLED score is 3. And she is currently treated with dabigatran 150 milligrams twice daily. And she had a stent due to non-STEMI 6 months earlier. She received a drug-eluting stent, and she's now on aspirin as well as dabigatran twice daily. And she presents to the ER with what we call a moderate intensity GI bleed. Her current hemoglobin level is 9.6. Her creatinine clearance is 66, and she's hemodynamically stable. Her last dose of dabigatran she took it 5 hours prior to admission to the ER. Now, we are all familiar with the established safety and efficacy of dabigatran, and I think that we reviewed it thoroughly in this session, so let's just move on. And of course, we just heard from Ronen about the higher risk of triple therapy as compared to either a dual therapy or what we call a single dual antiplatelet drugs. So the first question to my colleagues is, maybe we'll start with Doron. Would you change anything with the management of this patient prior to admission to the ER? Let me remind you of her characteristics. She is 79. Her CHADS VASC is 4. Her HAS-BLED score is 3. And she is receiving a 150 BID of dabigatran as in concomitant with aspirin, and she just had a stent 6 months earlier due to STEMI, non-STEMI. Would you change anything?
This very stable treatment. First, because she had triple the dual and the therapy, she should receive the 110 dose rather than the 150 dose. But even without that, in a few months, she'll turn 80 to Sheba, and then you will have to reduce her dabigatran dose anyway, even without the aspirin. Then, I don't know if it makes a difference, but the usual recommendation is once you stop triple therapy, you should stop the aspirin rather than the pill. Maybe this has effect of GI, I'm not sure. But yeah, basically I would give her pill and 110 or low dose of another between 3 to 6 months and 1 year.
Professor Bernstein, would you treat her differently? What would you do if her CHADS VAS score would have been 6 or 7? Would you still remain with the 150? I know that you don't have the 110 in the US. But no, she hasn't had a GI bleed prior to admission to the ER. You just you are for the case, you are the cardiologist, and you just so would you still choose the 150 after she received the stent if she had a higher CHADS VAS score? So the CHADS VAS score is not a factor once the patient has an ACS or an AF with PCI for any other reason. All right. Any other comments from or questions from the audience? So if not, then let's move on. So she's now Elad. She's now in the ER. What would you do first? Would you assess her renal function, her coagulation status, or would you go directly to any what I call a dabigatran specific measures maybe dialysis, or maybe give her a Praxbind, the antidote?
Yeah, so first of all, I think if she's stable, first you can assess the nerve function and coagulation, and then you can think, you're probably going to stop everything right now. The aspirin is still going to be in the blood for another couple of days. And if she's still going up, I'm not sure I'm going to give the antidote. Completely watch her in the approach whether or not you're going to be intensive care unit for sure. If she, let's say, if she's telling us that, today she had vomiting, blood, or something that's really concern us, then I would give her that. If not, just watch her and see what's going on.
Would any of you choose to measure the anti-10A or any other coagulation test? I'm sorry? And not anti-10A, I'm sorry. Drug levels or any other coagulation test?
I think the results from the reverse trial show that the PT track perfectly the lifetime, and that's reassuring that at least in the setting of bleeding, it's more powerful for both anticoagulation and reversal of anticoagulation. And I guess I don't treat PRP, but I guess I might consider giving her a Proxine just to make it safe for her to be scoped, potentially extended, treated with anything that might be visible, and she can be anticoagulated 24 hours after the dose of practical. So we really want to take me out of the equation for 1 day, which probably is safe.
Doron, would you do the same? Would you give her Praxbind? I mean, let me remind you that she had a stent, a drug-eluting stent, 6 months earlier. Are you concerned with stent thrombosis in such a situation?
And without much data today, and just as Ron said, I would have to be convinced that I really was going to back against the wall to do that. And I may not be because we all know the plan is the best antidote, or a good antidote, not the best right now. And if the patient's stable enough, I guess I can maybe give it to her.
Yeah.
I have a question for the cardiologist. Is it the general thought that dabigatran has some properties like prevent stents from thrombosis, because my understanding is most of the antiplatelet agents, which are not reversing, actually prevent thrombosis.
I would ask it differently with the panelists, and maybe someone from the audience has a different view. But in a patient who is receiving a stent, and is anybody here in the audience or the panelists concerned with the previous data with dabigatran, with the regard to the increase in cases of MI, or would you switch her from dabigatran to Eliquis, for example, when she received the stent? Would anybody do that? Does anybody do that routinely in the audience? If she is on the dabigatran, everybody would continue dabigatran. Nobody is concerned.
Plus, she's getting anticoagulation.
I'm sorry?
Plus, she's getting anticoagulation in addition to a year.
Yes, she is. She is. So you're not concerned. Yes, please. Did you want to comment? Yes, please.
I would say that in part the most scope level C an untreatable lesion, because you might treat the needles and actually stop the bleeding, you may be able to continue coagulation.
So you would take her directly to the to endoscopy, or
Option that you may find something, at least in my stomach, within maybe you can fix it, because otherwise these needles, such needles may erupt again and again, and we cannot control it, and we cannot predict it.
okay? Anybody else with different approach? Okay, so let's review the data. Let's see what we have. So the increase in GI bleeding with dabigatran has been shown in the RELY study, and although the major bleeding rate was, of course, not significantly different, but there is an increase in GI bleeding with dabigatran, and of course, that takes us to the question whether this is of any concern to anybody in a patient who had a previous GI bleed. Would you choose another? Would you switch her now to Eliquis after she had a GI bleeding, Doron? Would you do that?
I would, if she had a GI bleeding on things that, especially at this age, and without the association with GI bleeding, especially into the elderly, I would switch it to a drug that is not associated with GI bleeding at all.
You would, Professor Bernstein. Would you do the same?
Yes.
You would. Anybody would continue dabigatran in such a patient, or you would all switch her to Eliquis? Great. So we have a consensus. Okay. Would anybody consider hemodialysis or giving any PCC or a factor 7 concentrate or any other factors? None of you. And what would you do if this patient had severe bleeding? Would you treat her differently? Not she wouldn't have been hemodynamically stable. How would you take care of this patient? Don't. You would use immediately none of the other measures, not dialysis, not PCC, not factor 7. But the antidote is not available right now, right?
There was one interesting situation 90 patient cohort that has been recruited. He took about 150 capsules of AXA 150 as a suicide attempt and was given the antidote in preparation for putting the dialysis catheter in, and her coags normalized, and she ended up not needing dialysis. So I think it's a really potent option.
All right. Does anybody, are you able in the US to measure dabigatran levels?
I think not in real time. I think you can send blood to a central laboratory at BI in Connecticut, but not in the time of action. So we use the proton. Do you have the proton time in Israel?
The Hemoclot, I think some hospitals do. Professor Bano?
Actually, we do. For example, the program we have on the page, you can measure basically 24 hours, 24/7 if you do any duty. And I would actually not recommend to go by the PPT. Not the way to go. We have the test, and we have to use the test. And when the patient is bleeding, we need to get more information and to know and to measure the level, to know how much is left. And then this will guide better our management of such patients or potentially having severe or life-threatening bleeding.
Even though there is data, and I'm just showing you the slide, that there is a correlation between the drug level and the PTT level. It's not a linear correlation. So what the data really shows is that once the PTT level is above twice the upper normal level, that correlates with the drug level of more than 200 nanograms per ml, which increases significantly the bleeding risk. So maybe that may be used as a tool for assessing the bleeding risk. And then maybe you can consider either we don't have the Proxbind right now, but maybe a PCC or a factor 7 concentrate as an option. Would does anybody 7A, of course, 7A. Sorry. Um, and going back to the U.S., do you think that there is any benefit in routine measurements of drug levels as a instead of just looking at the renal function?
There could be, as a subject that has to be studied in a systematic. And the inter-individual drug levels, from what I've read, are so variable that even measuring them at one time is probably not a reliable dose. And we really only have one dose available in medicine.
Okay. Okay, Doron.
If we had your capabilities of doing it routinely for Hemoclot, which is not FDA approved in the United States, I think it might be.
All right. Is anybody using the Hemoclot in here in Israel except for in Rambam? Not you. Okay. All right. So let's move on. So there is a correlation between the Hemoclot and the drug level as well, and as we can see here. So what happened with our patient? Her renal function were normal, as you can see here. The creatinine clearance was 66. Her PTT was 2.5 times the upper limit normal, so she had a moderate risk of bleeding. We discontinued the aspirin and we stopped the Prodax, of course. And as you can see in the RELIGHT study, most of the patients who were on dabigatran received any blood transfusions, who had the bleeding, of course, received blood transfusions or fresh frozen plasma, even though there is no real data that's showing that fresh frozen plasma is really of any help. Professor Bernstein, what do you think? Would you give her a fresh frozen plasma? Okay. Okay, so going back to the patient now, she has recovered from her GI bleeding. Dawn, when would you consider restarting the anticoagulants?
Whether it can be reversed, whether we found a source. Obviously, if the source has been found and taken care of, that's easy. If not, then what I read earlier about the possible need for a preoperatively in patients who get less than 100 capsules.
Assuming that no clear source for bleeding has been discovered, would you consider restarting it a day or 2 days after the bleeding stopped, or and her hemoglobin level is being stabilized, or?
I would wait a bit more. If the source is not enough, maybe a week, make sure there's no bleeding. Then, as I said, choosing a blood survey that I think is
Elad, how would you?
I would wait also because the chances for stroke in the next week is very low, but the chances for bleeding out is much higher. But I think the question is what would we do with the aspirin because she needs to have something on board. I'm not sure aspirin is the right choice.
So you would consider restarting clopidogrel without the NOAC, just clopidogrel.
I would consider it after at least 5 days.
How does the stroke risk affect your management, Professor Bernstein? I mean, in such a patient, how long would you wait till you restart the nodes?
I'm very glad that wouldn't be my decision. It would really depend on what the source of the bleeding was. As a neurologist, I have the privilege of just saying restart anticoagulation when possible.
Doron, would you keep her on just a NOAC without any antiplatelet in this stage? She's been 6 months after she received the drug-eluting stent.
At this stage, 6 months out, late,
Does the stent type make any difference for you, Elad, or for you, Doron?
No, I think actually the name is right. I mean, just remember that she was a non-standing. She's 79. I don't care pretty much about the stance what she had because nowadays most of the time you put second generation drug-eluting stents. I think the majority of the patients. So actually they're good. The stent components ratio is very low.
Does anybody routinely administer PPIs with NOACs, or this is not a common practice? Elad,
Just the notes, maybe not.
you would. Professor Bernstein, how about you?
I don't generally do it on a routine basis.
Even in a 79-year-old patient?
I would say I don't
Mhm. Okay. Anybody else? Okay.
maybe I would like to check the prof stuff. Maybe should we study before? Should we, after she got the stent, then she got the stuff. That kind of stuff can maybe prevent future bleeding.
Okay. Good idea. All right. Uh, so you wouldn't consider any other measures if the bleeding would have been in a patient with a high risk of stroke. You wouldn't change any of your managements. I mean, just the same.
I guess one situation is if someone had a stroke, say, 3 weeks ago, and has a left atrial flutter, I might restart temporarily. If we did it as a sort of anticoagulation tolerance test, we could easily shut off, we titrated, keep them in the hospital under observation prior to starting an oral agent. We usually treat them in people with large hemispheric strokes before we start a NOAC. We'll use IV heparin for just a few days to ensure that they're stable. This is not evidence-based.
Elad, how would you treat her if she had a stent 3 months earlier, not 6 months?
Again, if it's a stent, it's one thing. If it's ACS and one thing, it's another thing. It's a left middle proximity is one thing. If it's distant proximity is another thing. So you have to take all these into consideration. But if she had a stent 3 months ago, let's say in the marginal artery, maybe I would stop it for the sleep.
So the territory and the patient's risk are still a factor. All right, great. Any comments from the audience? Anybody want to comment on N, or did he leave already? Okay, so the patient was switched to 110 of dabigatran. She wasn't switched to a Eliquis, which I would do as well, and discontinued on of the antiplatelet agent. And I think what I try to show in this case is that there is a variability between patients, and I think that every patient should be individualized. Even though our main goal is to prevent stroke, I think that safety is still a significant issue, and we should all be aware of that. So just let's move quickly to another case, which is a planned surgery in a 75-year-old woman. She's hypertensive. She had a TIA 5 years earlier, and she has I'm sorry. Um, she has been on dabigatran 150 twice daily for 2 years, and her creatinine level is creatinine clearance is 51. She is 75 kilos. She is scheduled for a total hip replacement with spinal anesthesia, and she's told to stop her dabigatran 48 hours prior to surgery. Doron, do you think this is appropriate management in such a patient? 75 with a creatinine clearance of 51.
For spinal surgery, I would definitely stop it earlier. It's a very high risk of surgery in terms of bleeding, and as was mentioned before, the risk of embolism in at least 1 or 2 additional days is negligible. And this being, topical surgery, that would not be a problem. With this type of surgery, I would stop it earlier. So the border anesthesia.
Earlier, like 3 days or 4 days?
The surgery,
4 days.
the clearance is 1 ml amount what would necessitate only.
Okay, maybe Professor Bernstein. This patient has a CHAS VASC of 6, if I am not wrong, and again, she's in high bleeding risk. She's in a very high risk of stroke. Aren't you afraid that she might suffer a stroke in those 4 days that Doron wants to stop the dabigatran?
Of course, I think 48 hours is probably enough, but it should be 4 half-lives, and her 70, I can't say 72 hours is wrong. I honestly don't know what advantage there is to be able to be on 72 hours with 6 half-lives.
Does the patient's stroke risk make any difference to you, or just the bleeding risk?
Now, I think the risk of bleeding from the surgery and the 5cc bleed in the spinal canal is massive. So this is someone who I decided not on rather than sure.
All right, Elad, would you do the same? Yeah. Okay. All right. Uh, Again, does it make any difference to any of you if the patient is in paroxysmal AFib or in chronic AFib? Does that make any difference for the risk of stroke, or would you consider it as a factor in your? Is there any data on chronic versus paroxysmal AFib risk in these patients?
There is this very interesting analysis from the Amaryllis study, the Aspen Aspen versus Pixaban, showing, contrary to what we've already thought, that the higher the burden of AFib, the higher the risk of stroke, comparing permanent, paroxysmal permanent, and persistent. Yes, so the more they're in AFib, the higher the risk of stroke, which is not what we've been taught. And now with the implantable devices where we detect them tiny burdens of AFib, the risk of stroke in those situations is unclear. But I think for this patient with a plain old framing hernia, whether it's paroxysmal or not, didn't affect my decision.
All right. So you would sure.
I think that this patient is actually the highest risk is actually for primary embolism
So following the surgery. So the next question is, of course, when would you resume the NOACs? This is just to make it shorter.
when well, it depends whether you still have spinal chapter or not. But usually what we do is we give trauma
So you believe that low molecular weight heparins are more efficacious and more safe in this situation than the NOACs, or is it based on any? All right. When would any of you restart the NOAC, Doron?
But to rephrase what the person said, I would do it with the surgeon.
When the surgeon permits. That might
My
be.
job is to tell the story. I don't know if this is a standard therapy.
Would you use low molecular weight heparins just to prevent DVT in such a patient early after the surgery? You would. Elad?
But I think in this case, she needs as soon as possible. It's going to be in her blood 3 minutes after she gets it, so that's enough for her. Unless the surgeon tells me no, for the next 3 to 5 days, so maybe yes.
All right. Professor Bernstein, any other opinions? Nothing. All right. All right. The most, I think, one of the interesting data from the real-life study is the increased risk of bleeding that was observed more than 72 hours after the procedures, and I think I would like to hear your explanation as compared to warfarin, which is somewhat surprising in a way. How do you explain it, Doron? Any thoughts?
I don't know, but it's also analysis of subgroups.
It's such a late hour. Okay, so let's move on with it. All right. All right, so these are the guidelines, and you were all seen it before, so I'm not going to stop and review it. But the creatinine clearance, of course, is a major factor in the decision of when to stop and for how long, and of course the type of surgery is also of importance, whether this is a low bleeding risk procedure or not. And I think that this is what most of us would do. We would wait a little bit longer just not to endanger the patient. We discussed it, so let's move on just to the last case, which is going to be a short one. All right, great. Thanks for the panelists. Thank you very much. Thank you.